morning. We are going to discuss part of Unit 6 at this time, Chapters 8, 9, and 10. At another date, I'll record Chapter 11 and 12. Chapter 8 is on anti-infectives or antibacterial drugs. One of the most important discoveries years ago, of course, was antibiotics. And a bacterial disease prior to antibiotics was a major cause of disease and death. An infection is an invasion by microorganisms that disturbs the normal environment of the body and causes harm or disease. Infectious agents can be bacteria, virus, fungi, protozoa, other microorganisms. And we know that bacterial infections are worldwide and certainly can lead to serious infections, disease, and even death. Most daily interaction with bacteria is harmless, but some of it can cause harm and become pathogenic, which means they can cause infection, systemic disease, and tissue damage. Some bacteria are non-pathogenic and they coexist with us on a daily basis, such as staph. Staph is very commonly found under our fingernails. We get it through dirt and that sort of stuff. So we can carry a bacteria and it not be pathogenic. And normal flora are the non-pathogenic bacteria that we always have on our skin, mucous membranes, and in the digestive tract. They provide protection by crowding out the pathogenic organisms and preventing them from entering the body. And normal flora we hear about very often is in our GI tract, and we take yogurt, things like that nowadays to increase the normal flora in our GI tract. And many times some medications can, or the overuse of antibiotics can decrease that normal flora in our GI tract, and then that can cause disease. But in general, we have bacteria always in our skin, our mucous membranes, and as I mentioned before, under our nails, that sort of thing. Opportunistic bacteria can cause disease and tissue damage only in someone whose immune system is not working well. So many then bacteria can be very dangerous, especially, as we've said before, to the elderly, to the children, to people with underlying diseases. The features of bacteria are single-cell organisms that have their own DNA and genes, cytoplasm, organelles, and membranes. Unlike human cells, bacterial cells may also have several layers of membranes and cell wall and capsules or coats. Bacterial types vary in the ability to invade a person and cause an inflammatory response. The virulence of the bacteria is a measure of how well they can invade and spread despite the person's normal immune. So virulence, I always think of as how strong the bacteria is. And we know bacteria are categorized as gram-negative and gram-positive. And when you take a culture, the physician will order a culture and sensitivity. So he'll culture the wound to find out what bacteria is in there. And then they put a dye on it called a gram stain. And those that change color are called gram-positive. And those that do not are called gram-negative. In general, gram-negative bacteria are more virulent and are harder to kill because they are surrounded by that protective capsule. So if they have that protective capsule around them, when you stain them in the lab with dye, then the dye can't get in because of that protective capsule, and they're called gram-negative because they did not take in that dye. Very, very interesting. So some antibacterial drugs are bactericidal, and that means they kill the bacteria directly. And then there are bacteriostatic, which means they prevent the bacteria from reproducing until the body's own white blood cells and antibodies can get control of them. So they sort of delay. They don't kill the bacteria. They delay. So if your immune system is not working and your WBCs are low, then the bacterial static meds aren't going to be as effective because your immune system is not working the way it needs to. Antibacterial drugs are sometimes described by their spectrum of efficacy, which is a measure of how many different types of bacteria the drug can kill or prevent from growing. Each drug is judged by how many types of bacteria are susceptible. So when the physician gets his culture and sensitivity, it also lists, and you'll see that, which drugs, which medications that bacteria is susceptible to. So then he will know which ones to order. There are a lot of information here about general issues in antibacterial therapy, and I will let you read all that. Certainly signs and symptoms. They talk about Pseudomonas membranous colitis, and that's a complication of antibacterial therapy that causes severe inflammation of the colon. Other names are antibiotic-associated colitis, and the cause of this is an overgrowth of the intestinal organism called Clostridium difficile, and that's called C. diff. And you'll hear the physician order a C. diff from the lab. And what happens many times is too many antibiotics will kind of sterilize the gut, and this bacteria then will take over, and the patient will get Clostridium difficile, which we call C. diff. It used to be very common, more common in nursing home patients, those who have immune systems that are compromised. However, the disease is becoming more prevalent, and so you'll see people who've had short-term illnesses or whatever, who've been on a couple of rounds of antibiotic, can certainly get C. diff, and it causes your bowels to cramp, and you can have bloody stools, bright red blood, active bleeding in the GI tract, and so the patient then can get very certainly dehydrated, anemic, very serious. C. diff is a very serious problem. Powerful toxin that takes over the intestines, so you need to read that about that. Let's see. A lot of information there on teaching. So we have types of antibacterial drugs. You have cell wall synthesis inhibitors, and they are bactericidal. And when we talked about bactericidal, what did we mean? Those kill the bacteria directly. And examples are amoxicillin, the penicillins, Pen G, Pen V, Pen K, the Ancefs, Rocephin, Zactam, Vancomycin. Many types of antibiotics are considered bactericidal. They kill the bacteria. And then you have protein synthesis inhibitors. Those are bacteriostatic or bactericidal. And those are aminoglycosides such as amikacin, streptomycin, very common. So you have aminoglycosides, macrolides, tetracyclines, lincosides, and oxazolidine, and streptogrammins. Those are the categories of protein synthesis inhibitors. Then you have metabolism inhibitors. Those are bacteriostatic, and those are your sulfonamides, your sulfa drugs, your trimethorprim, and combination drugs. And then you have DNA synthesis inhibitors. Those are bactericidal, and those are your fluoroquinolones, and that is Cipro, Levaquin. Levaquin's a very often used medication nowadays, very strong, not often used, but very strong. Floxin, that's another one. So you need to know that category. Table 8.1, actions of antibacterial agents. It tells you how they act, what they do, and what the categories of each one of those medicines are. So cell wall synthesis inhibitors, they're the class that kill the bacteria by preventing them from forming strong protective cell walls. So cell wall synthesis inhibitors. So it tells you, it prevents them from having that cell wall, that protective wall around the cell. And like it says, there are many of these drugs, first generation, second generation drugs, and the generation refers to the stage of development of each one of the drugs, which their original generation, the second generation comes and they've changed it a little bit, makes it safer for the patient to receive. And of the cell wall, as I told you before, there's penicillin, cephalosporins, monobactams, carbinamines, and others. That's the categories of the cell wall. The cell wall prevents the wall from forming around the bacteria. Okay, side effects, of course, penicillins, diarrhea and itchiness, the carbinamines and vancomycin, IV site reaction. They're very hard on the veins, very hard on the veins. Very important as a nurse that you watch those IV sites, or even if the patient complains of pain and burning, don't ignore the patient. I've seen over my lifetime nurses who didn't want to take the time to change the IV site, and the patient got a really bad phlebitis. So if the patient says it hurts, you need to investigate the site. And now sometimes medications just make them burn a little bit, but you need to watch that site and make sure it's not getting red, hard. Very, very dangerous with phlebitis in many patients. So IV site reaction and reduced kidney function, as we've talked about before, and hearing. It can cause side effect of ringing, tinnitus in the ear, that sort of thing. Vancomycin is a very strong medication, and you can get red man syndrome with vancomycin, which we've talked about before, and that's flush redness, that sort of thing. Upper back, arm pain, reduced hearing, greatly reduced kidney function. So usually before vancomycin is given, there's a kidney function study done prior to initiation of vancomycin and other drugs, but vancomycin in particular because of the concern about reduced kidney function. So they can't take it if their kidneys are not functioning properly. Adverse effects. The carbinamines may cause serious central nervous system changes, including confusion and seizures. So just be sure and pay attention to all of this, including what I talked about, red man syndrome, that sort of thing. Okay, then we have protein synthesis inhibitors. That's the aminoglycosides, macrolides, tetracyclines, and other protein synthesis inhibitors. And these drugs prevent the bacteria from making proteins important to the life cycle and infective process. So protein synthesis inhibitors, so you remember that, it prevents this protein from being reproduced. As a result, the bacteria will either die or not be able to reproduce. Protein synthesis inhibitors work on different parts of this entire pathophysiology process to stop the bacterium from being able to live and reproduce. And then it talks about how each one of them work. I'm not going to go through all of the pathophysiology on this lecture, but I want you to read those and understand the different, try to get the understanding of the pathophysiology in your mind, okay? I will try to help you further with maybe some helpful hints if I'm going to get much into the pathophysiology, but mainly I want you to know what the broad categories, what those do. I do want you to know the side effects. Okay, so the common meds for aminoglycosides are amikacin, streptomycin. You've all heard of streptomycin. The macrolides are zithromax, emycin. You've heard of those. Tetracyclines. And tetracyclines are used, we've heard about that, for Rocky Mountain spotted fever, especially Lyme disease, typhoid fever. It's important to know that your patient would probably receive a tetracycline. And then you have the lincosamides, that one's harder to say, oxazolidones, and the streptogramins. Okay. And the last three are very powerful drugs with severe side effects. You need to read those. Those are used mainly for what we call VRE and MRSA. And VRE is vancomycin resistant enterococcus and methicillin resistant Staphylococcus aureus. And MSRA, very serious, and now VRE. But again, used to be found, methicillin resistant especially was found mostly in nursing homes. And back probably in the late 80s, early 90s, we started seeing methicillin resistant organisms in the hospital setting. And now, unfortunately, they are not uncommon. That's why patients are moved through the hospital system as fast as possible so that they're not exposed to these resistant type organisms. And why it's so very, very important for nurses to wash their hands and not spread a bacterium from one patient to another, because that's how they're spread. One of my pet peeves is to see a Foley bag sitting on the floor. You need to raise that bed up. Make sure that Foley bag is not touching the floor. You can imagine the number of germs that are on a hospital floor, and you need to pay attention to your patient. You need to protect your patient. You need to wear gloves. You need to wash your hands upon entering and exiting the room. After touching your patient, you need to remove those gloves. If those gloves are soiled, you need to put on a clean pair of gloves. You just need to think about these two very severe resistant organisms. And what's happened is patients have taken these meds, very strong, then this bacteria has developed over time that is resistant. So the protein synthesis inhibitors that are very strong are now have resistant bacterial organisms. So they don't help the patient. And the patient is usually very, very sick if they're starting to take one of these meds. And now the medicines are all resistant. So we need to nip this problem before it ever happens. And patients should not be exposed to these bacteria-resistant organisms. So, and it starts with us in the hospital setting and at home if you're taking care of a patient, or if you're doing home health or whatever. But you need to wash your hands, wear gloves, protect your patient, keep those Foleys, and any other equipment that suction canisters and tubing that you're going to put in somebody's mouth. You know, don't let it dangle on the floor. I have seen that happen. So you need to protect your patient. Now, off of my soapbox. Okay, the side effects are listed here separately. Aminoglycosides, and they can cause vomiting, rash, etc. Macrolides affect the GI tract, photosensitivity, tetracycline, sore tongue. We've heard about some of the issues with tetracycline, clindamycin, rash, etc. Adverse effects: aminoglycosides are highly toxic to the ears and kidneys, causing hearing loss and reduced kidney function. And clindamycin, streptomycin is a common one that we have to watch out for that. So highly toxic to the ears and kidneys. Inner ear, I won't talk about that. Macrolides especially have a lot of drug interactions. So if they're taking digoxin, anytime a patient's on digoxin, dilantin, some of those common ones that we talk about, we need to pay attention to drug interactions. Then tetracyclines, they can cause increased intracranial pressure. Imagine. So you certainly would be careful if a patient was on seizure medication, you sure don't want to increase intracranial pressure. And it also affects the ears with tinnitus. Clindamycin affects the liver and WBC counts, etc. And what to do, you certainly need to read all of that, but you're going to watch their lab, and you're going to check their blood pressure. You're going to look for any kind of side effects that you know that they could be having. And then we have other protein synthesis inhibitors. As I've said before, many of them affect kidneys, so you're going to do BUN and creatinine levels, that sort of thing. What to teach, you can read about that. Certainly we know, and we've heard, tetracyclines should not be used in children younger than 8 years of age. We've heard about birth defects that in pregnant women. So tetracyclines are very dangerous in children. That can cause the tooth enamel to go away, as well as other serious issues. Okay, we have metabolism inhibitors, sulfonamides and trimethoprim. They interfere with the bacterial reproduction by preventing the bacteria from making folic acid. So the bacteria needs folic acid in order to reproduce, and these prevent the bacteria from making that folic acid. Then these are sulfonamides and combination drugs that are listed there. On the sulfonamides, one of the most serious effects is suppression of bone marrow cell division. This results in anemia and fever, white blood cells are down, etc. A simple rash can occur, but we can get more serious side effects called Stevens-Johnson syndrome, and that's when blisters form on the skin and the skin actually sloughs off. Very serious. Stevens-Johnson syndrome. Okay, then moving down, these patients can get jaundice, so you're going to watch the sclera of their eye for yellowing, and you're going to watch for their abdomen. Certainly we don't want liver enlargement, so you're going to be watching all kinds of liver inflammation signs and symptoms. You're going to check whether a patient is taking a thiazide diuretic, and you want to encourage them to drink sulfonamides with a full glass of water. What to do before, what to do after, you need to read about those. DNA synthesis inhibitors, fluoroquinolones. These drugs have many uses when taken systemically, and they're used a lot of times in eye drops and eardrop medicine. The most common uses for skin infections: urinary tract infection, respiratory tract, diarrhea, gonorrhea, and they're used for anthrax. Fluoroquinolones, they are DNA synthesis inhibitors that enter bacterial cells and prevent bacterial reproduction by suppressing the action of two enzymes important in making bacterial DNA. They are bactericidal to most bacteria that are sensitive to these drugs. So they prevent that DNA synthesis, which is what the name says. Fluoroquinolones. And that is Cipro, very common. Floxin, very common. Levaquin, very common. You will see those. And with those comes rash, nausea, vomiting, abdominal pain, that sort of thing. Adverse effects can cause heart dysrhythmias and cause a prolonged QT, and y'all studied now the QT interval, and that can become prolonged, which can cause serious heart problems. And especially if they're taking some heart medications like amiodarone. We studied amiodarone, and to mix that then with this antibiotic would be very, very serious. They can get hypokalemia, peripheral neuropathy, hyper and hypoglycemia. So it's a very, very strong medication. You need to check patients' diabetes levels. We talked a little bit about when antibiotics are overused, and that's one of the nation's problems and why physicians really control the use of antibiotics, because they can become resistant. And you can get multiple drug resistant organisms, or MDR, and which would not be good at all, because then you narrow the number of antibiotics that you can use. And we talked about MRSA and the other resistant types. Okay, moving to Chapter 9, Anti-Infectives and Antiviral. Viral infections, of course, are very common, and I know when you take your children probably to the doctor, you don't want to hear him say they have a viral infection, because then you don't get antibiotics. But they're very common, like the cold. They're non-life-threatening, and no drug is usually needed. Others, such as hepatitis, is a viral that is more complicated, and left untreated could cause severe damage. So viruses are intracellular, submicroscopic parasites that must infect a living host to reproduce. So they have to get into the living host. A host is the person infected by the virus whose cells allow that virus reproduction. Okay, there are two basic types. There's the common viruses, the non-retroviruses, and retroviruses. Likewise, there are two basic categories of antiviral drugs: those that work against some common viruses, antiviral drugs, and those that have some effect against retroviruses, or antiretrovirals. So the first we're going to talk about are the common viruses and the pathophysiology of that. A common virus is non-retrovirus that uses DNA or RNA as its genetic material and has relatively low efficacy of cellular infection. And we talked about efficacy prior. Efficacy of the infection is the ease with which the organism can cause disease through infection. So I always think of it as how strong it is. This means that most common viruses must invade the body in large numbers to cause disease. These viruses are responsible for common infections such as chickenpox, shingles, measles, mumps, herpes, warts, hepatitis, and the common cold. And so the figure 9.2 shows an infected cell and how it generates new viruses, then opens the cell and sends the new viruses out to infect the host. Some common viruses are stronger than others with greater virulence. And that means how easily they can enter a new cell and cause problems. One of the most virulent viruses is the hepatitis B virus. Other groups, like the common cold, is less virulent. An important concept to remember for all antiviral drugs is that they are virostatic. These drugs reduce the number of viruses by preventing them from reproducing and growing, kind of like bacteriostatic, virostatic. And they prevent the virus from reproducing and growing. They are not virucidal and cannot kill the virus. Okay? Virostatic, they just prevent it. They slow it down. Antiviral drugs are virostatic. They prevent viruses from either reproducing or from releasing their genetic material. Drugs that are effective against common viruses do not have specific categories and may have more than one mechanism of action. So, before giving, you can read all of that. It's pretty much the same. Check their vital signs, check for any meds they're already taking, and watch IV sites, all that sort of thing. Common antiviral drugs are listed on page 140. Aclavir, we've heard about, ribavirin, Tamiflu, you all know about Tamiflu, Valtrex. These are antivirals. So aclavir and valcyclovir are two drugs that work at the cell level. They slow viral reproduction by forming counterfeit DNA bases and inhibiting the enzymes needed to complete the formation of the DNA chain. So they form a counterfeit DNA. Again, if the patient is on Dilantin, you need to know that. The diseases caused by the different specific viruses, like the Epstein-Barr virus causes chronic fatigue, some lymphoma. The hepatitis A, of course, causes hepatitis A. The B causes chronic hepatitis B, liver failure, liver cancer. So these are the viruses listed in Table 9.1 and the disease that they cause. Okay, we're going to talk about atofovir diprovoxyl, and this is an oral drug that acts as a counterfeit base, limiting the DNA replication and reproduction of the hepatitis B. So this is the med that we would give for hepatitis B. These actions suppress the viral replication in infected cells, especially in the liver. As you know, hepatitis B affects the liver. Unlike some antiviral drugs, the duration of therapy with this drug may be months or years. If you've been infected with hepatitis B and have to go on one of these meds, then you, as a nurse, then you would take it oftentimes for months or years. It has many adverse effects and includes carrying a black box warning, and you know about black box warnings from Chapter 1. This drug is highly liver toxic and kidney toxic. It should be used in caution with anyone with impaired liver or kidney disease. It also interacts with many drugs. The other drug, amidantin and rimidantine, these prevent viral infections by blocking the opening of the external coating of the influenza A virus and stopping the release of viral particles into respiratory epithelial cells. Most common side effect is these anticholinergic effects that you've read about: blurred vision, dry mouth, hallucinations, etc. Those are on the side of the page there. Ribavirin is a counterfeit base that suppresses viral action and reproduction, and it's not really known how. It has many side effects. It's used to treat hepatitis A, C, the RSV virus, and West Nile viruses, among many, many more. It's a potent drug with many adverse effects, and its use is limited to patients who have severe viral infections for which no other drugs are used. So RSV, when our babies have RSV, this is the medication that is usually used. We need to always check lung function, watch for jaundice, can interact with many meds, very, very big time serious drug. Oseltamivir and samivir, it inhibits neuroamnidase enzyme, which is needed to spread the viral particles in a respiratory tract. It must be taken within 12 to 48 hours, and the oseltamivir must be taken within 12 to 36 hours. So these are what are used for the flu, to make it simple. So Tamiflu, those meds are used, but there is a time limit for when you can start those drugs. If the patient comes in and said, you know, for days they've not been feeling good, then probably they won't get one of those meds. A retroviral infection is a virus that always uses RNA as its genetic material and carries with it enzyme reverse transcriptase, integrase, and protease, which allow high efficiency of cellular infection. This means that disease may result even when low level of retroviruses enter the body. It's a strong, strong virus. The human immune deficiency virus, or HIV, is a retrovirus that attacks the immune system of an infected person, eventually causing him to have little immunity protection. The most severe immune deficiency disease caused by HIV is known as the AIDS infection. Now, there's a lot of pathophysiology with this disease process. I want you to read it. As you know, AIDS is about T cells and CD4 plus T cells, and I'm not going to get so deep into pathophysiology. Each one of these categories, you need to know which one affects DNA, RNA, and you need to know this is the one that uses the RNA that causes these kind of milder viruses to enter and then cause AIDS, that sort of thing. General issues in antiretroviral therapy. Now, we're talking about the retroviral now. Are a broad category that suppress the replication of retroviruses, which uses the RNA as their primary genetic material instead of the DNA. The 6 classes are listed on page 147. Nucleoside analog reverse transcriptase inhibitors, or NRTIs. Non-nucleoside analog reverse transcriptase inhibitors, or NNRTIs. Protein inhibitors, integrase inhibitors, fusion and entry inhibitors. A patient with HIV receives drugs from several classes in regimens called cocktails. So they receive a cocktail of drug if they have HIV, because it's not controlled by any one antiviral alone. This approach is termed highly active antiretroviral therapy, or HAART, H-A-A-R-T. Highly active antiretroviral therapy. And these antiretroviral drugs are virustatic and do not kill the virus. And then they have been known to cause drug mutations, which is in the HIV organism, which even makes it harder to control. The viral load. The intended response is to reduce the viral load. And the viral load are the number of viral particles in a blood sample. So that, again, looks and sees how virulent, how many viral particles are in that blood sample. So you want that to be reduced, of course, when you give these meds. The immune function is improved, as evidenced by higher CD4 plus cell count, and the patient has fewer episodes of opportunistic infections, pneumonia being one of the most common in HIV that they get. Teach patients the same thing. Take their med as prescribed. Don't miss a dose. These do not kill the virus or cure the disease. They need to know that. They help reduce the number of viruses, the viral load. They help reduce. The person will still have the HIV disease. And certainly with pediatrics, the safety of these drugs have not been really established in HAART therapy for HIV, so very sad. Types of antiretroviral drugs are NRTIs, as I mentioned before, and these are listed on page 149, common side effects, what to teach the patient. Then you have the NNRTIs, and these are a class that inhibit the action of the enzyme reverse transcriptase by binding directly to the enzyme, preventing it from converting the viral RNA to DNA. As a result, viral reproduction is suppressed. And those are listed there. Protease inhibitors, they prevent HIV replication and prevent the release of HIV particles from infected cells. HIV produces its proteins, including those needed to move viral particles out of the host cell in one long strand. For the proteins to be active, this large protein must be broken down into separate, smaller proteins through the action of the viral enzyme HIV protease. So these inhibit that strand from being produced. And these all end in protease inhibitors. If you notice, the generic name ends in NAVIR. So that's one way to kind of recognize that category of protein inhibitors. It ends in NAVIR. So you'll see there on page 151. Then you have integrase inhibitors. These are usually prescribed for people who have HIV and that are already taking the heart and are beginning to have increased viral load. So their viral load is not going down. These have not been studied to be safe for children, but they are needed for patients that are not responding to that heart. And they have the kind of the same sort of side effects, except that they're just very, very strong drugs. Side effects: dizziness, headache, etc. They can cause rhabdomyolysis, and if you're taking a statin drug, they can cause this rhabdomyolysis if you're taking that statin drug, which statin drugs seem to affect a lot of muscles, muscle tone. You hear people complain of soreness in their feet and all, so somehow statin drugs affect muscles. You'll think about that. And so if they're taking this drug here, they can actually get rhabdomyolysis. Fusion inhibitors. This is a class that prevents infection by blocking the viral docking protein GP41 from fusing with a host cell. So again, without this fusion, the new cells cannot reproduce. And that medicine is enfuviratide. And these are it's injectable, and it usually comes in a 1 month dosage. And then entry inhibitors. The major drug in this category is Cellzentry, and it is a class that prevents HIV cellular infection by blocking a CCR5 receptor on the CD4 plus T cells. Again, the T cells in HIV, liver toxicity, etc. So this is just another big category of drug. New research for prevention of sexual transmission has resulted in the use of drug therapy for pre-exposure for prophylaxis, and you can read, it's called Truvada. You can read about that. Okay, so then we move to chapter 10, anti-infectives, anti-tubular, and antifungal drugs. Be sure, I will try to help you some on your quiz. Be sure and monitor your quiz for your homework and see which categories of drugs I try to pull out and glean from, because I know this is a lot, don't freak. I know this is a lot of pathophysiology. You just need to understand the categories, which ones are DNA, RNA, understand a little, as we talked about this cell synthesis and how these viruses get a cell wall around them, and know your categories of drugs. Okay, so we talk about the most common bacterial infection worldwide is TB. It's a highly communicable disease caused by the Mycobacterium tuberculosis bacteria. It's spread through aerosol transmission. You must know that. Aerosol transmission. And it transfers bacteria-filled droplets through the air when a person has active TB, coughs, laughs, sneezes, whistles, or sings. These droplets may then be inhaled by others, and you can see how prevalent then TB is becoming. Has been becoming for many years now. It is airborne. If you're around someone, you don't know if someone has TB that you're standing next to in the grocery store line and they cough or sneeze, or your patient coughs or sneezes in your face, and so you just don't know. And thus the risk for healthcare workers, and why we are checked annually for TB. It's for our safety and our protection. Once the bacteria is inhaled, it multiplies freely, and when they reach a susceptible site in the lungs and form the primary TB lesion is in the lung, which is a small inflamed pocket of bacteria, and then white blood cells and exudate. The lesion is surrounded by a lot of white blood cells, because it's inflammation, and then it causes pneumonitis. During this time, many people who have an intact immune system develop immunity to the TB organisms. And further growth of the bacteria is controlled by confining it, because your body surrounds itself with its own immune system, so you develop an immunity to it. These lesions usually resolve, leaving little or no residual bacteria, but they may show up on the chest x-ray as a scar. So you may have been infected, and then your body protected you, but it remains a scar on your chest x-ray. Only a small percentage of people initially infected with the bacteria ever develop active TB. Immune responses develop 2 to 10 weeks after the first infection with a TB organism, and can be detected by a positive reaction to the intradermal TB skin test that we talked about. And you see a picture here on the left of what the positive TB skin site would look like should you have your TB test and it come back positive. TB is slow growing, and the symptoms develop over years, and you may just need to watch yourself with a chest x-ray annually if you ever become positive. The first line anti-tubular tubercular drugs is given for 2 to 3 weeks until clinical improvement occurs. So figure 10.3 shows you how these anti-tubular drugs work, and with exception, most of the drugs either can be either bactericidal, which kills, or bacteriostatic, which suppresses, depending on the drug concentration. So the drugs that are usually used for TB are INH, what we call INH, RIF, and PZA and EMB. And usually INH is the one that you see ordered most likely. And you want the cough to be reduced. You want sputum, because they produce a lot of sputum. You want that to be reduced. You want them to gain weight, get more energy, and you need their sputum culture to be negative. So your physician will order a sputum culture and sensitivity, and you collect that through a little tube, and you have the patient cough, and then they take it downstairs and they do a culture and sensitivity, which is what we talked about earlier, to decide which med to give, and etc. Adverse effects are for each drug, and you can read about that. Peripheral neuropathy can come from INH, and is caused by a deficiency of the B complex vitamins, and can be prevented by increasing vitamin B during treatments. And just remember that these drugs must be given probably for 6 months or longer to be fully effective. Then we have fungal infections. Fungus is a simple organism with one or more cells, such as yeast, molds, and mushrooms, that produces spores, and they have walled cells and can either live peacefully or infect humans and cause disease. Fungi have a thick, tough cell wall and a plasma membrane that is made of materials different from bacterial cell walls. Fungi live in places that are moist and dark, and because of their tough cell walls, fungi can live easily on human skin and mucous membranes and are not completely removed by bathing. Some types, such as Candida, are part of our normal flora and do not cause problems unless they overgrow or enter the body. Without treatment, fungal infections remain and can become widespread, especially if your immune system is weakened. Superficial fungi are uncomfortable and change the appearance and function of the infected skin. When fungal infections enter the body by inhalation or breaks in the skin, deep fungal infections can result. When these fungal infections are deep, systemic drugs are needed to kill the fungi. And they're either fungicidal, so they kill, or they're fungostatic, which means they slow. Remember, bactericidal, bacterial static, fungicidal, fungal static. So the common drugs are azoles, which is diflucan is a common one. They can be polyenes, which is amphocyteratin B. That's a common one. Or Lamisil. You've heard of Lamisil. Those are kind of the common ones. Patient teaching tips for topical antifungal agents. Report any indication of allergic reaction. Immediately apply the drug. You need to wash your hands to get any traces of the drug off your hand. Avoid getting it in your eye. Use the drug exactly as prescribed and for as long as prescribed. And then there's powders and creams. And in creams, you remember, like in steroids, you apply a thin layer, but you want to apply it only on the area that is affected. And wash and dry right before reapplying the next dose. Loosely cover it. And then you have oral lozenges. Brush your teeth before using the tablet. Let the tablet dissolve, and then clean your toothpaste daily by running it through the dishwasher and bleach. Vaginal creams, use them right before going to bed. Wash your hands. Use the full applicator, etc. So you can read all that. And then the major categories are listed on 164. Intended responses, what to do. I kind of already went over that. What to teach patients, and certainly you want to teach them to report if the signs and symptoms are not improving, or if it's getting worse. You always make sure you want to, if you're giving it IV, you want to watch that IV site, and other things that are listed here in your book. So that's pretty much it for chapter 10, and I will record the other two chapters at a later time. Thanks.